All right, we're going to start Lesson 6, the last section of this phlebotomy class entitled Advanced Techniques and Skills. I'm working in the small book. You guys should, as I've noted, be reading your big book 3 times through. Make sure you get all the information. The small book is simply a highlight of what is talked about in detail in the big book, so make sure you read that textbook. All right, very first technique, therapeutic drug monitoring. Therapeutic drug monitoring are labs that are drawn to monitor very powerful drugs that are used. Sometimes these will be antibiotics like vancomycin, very powerful drug. If you get too much of it, it damages your liver. If you don't get enough of it, it doesn't cure the doesn't rid your body of the bacteria that's causing you a problem. So you have to find the therapeutic level. In order to do that, the drug is monitored, whether it's a cardiac drug, whether it's an antibiotic, whether it's a psychotropic drug, such as lithium, then that drug has to be monitored in the person's body in order to ensure they have a therapeutic level. So that's what is therapeutic drug monitoring. The way that occurs is levels called peaks and troughs are drawn periodically after a medication is given. The medication, once it's given, is going to metabolize in the body at a certain rate. At, say, 4 hours after a particular medication is given, the order is given to draw a peak. That means that the pharmacist, primarily if you're in a hospital, is looking to see if the medication has reached its peak, which they have already figured, at 4 hours. If it hasn't reached at 4 hours, then they probably will have to then look at the dosing of the drug. May have to change the dosing, may have to change the dosing interval, just depends. And then at a certain point, the pharmacist will also have figured the drug should be reaching its trough, the minimum concentration in the body, and they will order what's called a trough at that time. If it isn't at a minimum or isn't what they would expect, then again they may have to look at the dosing of the drug or the interval at which the drug is given. So that is therapeutic monitoring. Keep in mind, it's done on these drugs that are very powerful, that can harm instead of help if their levels are too high in the body. So when you get those, you have to make sure you are doing these when ordered. They are time critical. If for some reason you can't get it at that time and you get it late, you need to make a note of it in the chart so the doctor is aware of it. And these things are typically drawn in plain red tubes. We've talked about that. You can have red tubes with additives. Plain red tube is just a red tube with no additive. All right. Vascular access devices. We talk about those. That could be an IV, it could be an implanted port, it could be a central catheter up into the subclavian vein in this area beneath the clavicle subclavian. Could be a central venous line, meaning the catheter is inserted into a vein but has a long enough catheter that it ends up in the central venous system. Peripherally inserted, but ends up, because they'll have a long catheter, some of them have a catheter so long, and it'll thread all the way up and into the central venous system. These things some are installed by the nurse, some are installed by nurses with special training, such as a PICC line, peripherally inserted central catheter. So it'll have a long catheter inserted here, long catheter coming all the way up into the central portion of the body, though it is inserted peripherally. Peripherally inserted central catheter, PICC, PICC line. The thing for you to know is that you don't draw blood from them unless you have had special training and you're familiar with the access device. Typically, phlebotomists are not. We don't teach any of that here. In this course, you have to leave that up to the nurse unless you've had special training. If you go to a facility and they give you that special training, that's fine. Then you can access some of these devices. Otherwise, you contact the nurse. The central venous lines, the central catheters, the implanted ports, which would be under the skin up in the chest area here. Heparin or saline locks, which is simply the IV that most people see, the little IV sticking out of the hand or the arm. Those are not for you to access. Leave them alone. If you have no other means of getting blood, then go to the nurse, talk to the nurse, ask them to draw the blood for you. Don't assume that the nurse will know the order of draw. So leave everything in the that's going to be needed for the particular blood draw. Leave it at the bedside. Have the tubes in the proper order of draw. Have the system they're going to use to draw. Have it all laid out there because they're doing you a favor. Make it easy for them. And do not assume that they're going to know anything about phlebotomy. Unless things have changed in nursing school, nurses get no training in phlebotomy. So don't assume that they will. Cannulas and fistulas, these are typically appliances that are installed in a patient's arm, up in this area of the arm. Dialysis patients, that's where the dialysis nurse attaches their machinery to withdraw blood, cleanse the blood, and then put the blood back into the patient's body. Dialysis nurses can draw blood for you. They can draw venous blood. They can draw arterial blood. Thing for you to know is you do not touch these appliances. Don't bother cannulas and fistulas. Make sure if anybody's going to do it, it's a qualified dialysis nurse, because if these things become contaminated, they have to be removed surgically and new ones implanted surgically. It's a big deal. So leave that stuff alone. Third procedure, arterial blood gases. These are typically drawn by I'm drawing a blank now. These are typically drawn by the respiratory therapist. Phlebotomists typically don't draw arterial blood gases, but if you're going to do that, on the arm, just about an inch below the base of the thumb, is the radial artery. You feel it pulsing where nurses and doctors typically take a pulse. That's your radial artery. On the opposite side is the ulnar artery. The two arteries supply the hand. Arterial blood gases are typically drawn from the radial artery because it's very close to the surface. Before that can be done, you first have to ensure that both of these arteries are in fact supplying blood. Because if you do the procedure here, and if you're trained and qualified to do it, and you cause a clot in that artery, that means there is no oxygenated blood coming to the hand, unless it's coming through the ulnar artery. So you want to make sure the ulnar artery is functioning and what's called patent, open, before you start working on this one. You do that with a thing called the Allen's test. In your small book, the way it's described is not correct. So make sure you read in your big book how to do it, and I'm going to tell you about it. What you do is you take 2 fingers and you compress those arteries so that no blood is flowing to the hand. Blood is still leaving the hand by way of the veins, but no blood is moving to the hand through the arteries because you have them compressed. You should see the hand start to turn a little bit white, what they call blanched. Now, if you let go of the ulnar artery and you see the hand turn pink again, that means the ulnar artery is open and supplying blood to the hand, so therefore you're safe to work on the radial artery. Remember, if you cause a clot here in the process of doing the procedure, and the ulnar artery is not open and working, there will be no oxygenated blood moving to the hand. That's a bad situation. So make sure you perform the Allen's test, and make sure you get specialized training in how to do this procedure before you do it. If you're asked to do it and you don't know how, say so. Don't go in there and try to figure it out at the bedside. Okay, but do make sure in your big book you read about the Allen's test, because what they've described in your small workbook here is not correct. Blood cultures. Blood cultures are drawn when the doctor suspects that there is bacteria in the blood. Now, bacteria can get in the blood from an existing disease condition. Say, person has a bed sore on their buttocks from laying an open wound from laying in one position too long. The skin is broken down. They have a sore. It becomes infected. Bacteria from that wound gets into the blood. So you have bacteria. That is called bacteremia. Bacteria can also be introduced into the blood by not properly cleaning the skin or using dirty equipment, drawing blood. That's called septicemia. The end result is the same. You have bacteria in your blood, and if you have bacteria in your blood, then you have to assume and you have to know that that bacteria is traveling everywhere in the body that blood goes, and that is every single cell. So this is a serious condition. In order to test for the bacteria, you would draw a blood culture. Blood culture is drawn in two sets of two bottles, and I don't have them here because they're at the school and I can't get there to get them. Two sets of two bottles. Those bottles will be an aerobic bottle and an anaerobic bottle. Aerobic means that that tube is used to draw blood and to look for bacteria that likes to live in the presence of oxygen. Anaerobic is the bottle that's used to test for bacteria that doesn't like to be in the presence of oxygen. Anaerobic, anytime you see an A or an AN in front of something in healthcare, in front of a word in healthcare, it means without. So anaerobic means without air, without oxygen. All right. So you'll do two sets. You clean the arm. Typically you'll use chlorhexidine. Clean it just like you would to draw blood, but you're going to use chlorhexidine. You're going to clean the tops of the bottles with chlorhexidine. Let it dry, and then you're going to draw, and you can draw right into the tubes. The bottles are about this tall, a little bit rounder. They have a growth medium in the bottom, and the tube fits right into a large hub to which a needle is attached, and they are vacuumed, so it will draw the blood straight into the tube, into the bottles for you. And then you're going to complete the blood draw just as you would any other blood draw. Put a bandage across it. You're going to wait 15 to 30 minutes, and you're going to draw the second set of tubes on the other arm. You're never going to draw from the same location, from the other arm, in that timed interval of 15 to 30 minutes, depending on the policy at your particular facility. And you'll learn that when you get there. But that's an example of a timed interval. And something to be aware of is that you could also use iodine to clean, because this is going to be a sterile technique. But a lot of people are allergic to iodine, so more and more it's not being used. If you're going to use iodine, you have to ensure the person is not allergic to shellfish. Shellfish contain iodine. Better use chlorhexidine if you can, if it's available. If not, and you have to use iodine, make sure the person is not allergic to iodine. Okay. Once you've collected the blood in the tubes or the bottles, they need to be inverted a few times to mix them with the additives. And then they need to get to the lab, generally within an hour or so, but in most cases you're going to be getting them there a lot quicker than that. And again, read in the book, page 202, they go into great detail about the blood culture, doing the blood cultures. Read it and read it and read it at least 3 times. Next procedure is 2-hour postprandial blood sugar. That simply means 2 hours after eating, a blood sugar is drawn. In this case, what you're going to have the patient eat is 150 grams of this really thick, syrupy, sweet product called glucola, because it's a standardized 150 grams of carbohydrates. So the patient, after fasting, will take the glucola. 2 hours later, you draw a blood sugar. It's pretty simple. The procedure is exactly as the name states, 2-hour postprandial blood sugar. You would expect after 2 hours that the carbohydrate, which is converted to glucose in the body, will be cleared from the bloodstream. It takes about 2 hours after eating to normalize your blood sugars again. If it's not normalized, well, then that'll tell the doctor something about how the body is clearing glucose from the bloodstream. Pretty simple test. PKU specimen collection. Phenylketonuria, that's a genetic disorder in which phenylalanine is not converted into tyrosine. Tyrosine is an amino acid which is necessary for the proper development of the brain. So when a baby is born, this is one of the tests that's done generally within 24 to 72 hours. They do a little blood draw from the heel, and the genetic disorder is checked for, evaluated from that blood sample. It's a very simple procedure for the doctor then to prescribe the proper medication, and the child has no problems whatsoever. Without the proper medication and without the proper levels of tyrosine, the child can end up with brain damage. And so, simple test, and it's mandated by law in every state. It has to be done within 24 to 72 hours, and the parents really have no say-so in it. It's one of those tests that's done, mandated by the state, because it is for the welfare of the child. So it's done. Most parents never know it's done. They just get their child back from the nursery, and there's a Band-Aid on the heel, and they're asking what's wrong, and nothing. We just did some blood testing, and that's all they know. Really all they need to know. So that's PKU specimen collection done on children 24 to 72 hours after birth. A bleeding time test. A bleeding time test is real simple. Clean the arm in this area here, alcohol, just like you typically would. Take a standard lancet, which is going to give a 5 millimeter tall by 1 millimeter wide by 1 millimeter deep incision. You don't push it into the skin, you just push it up against the skin. You don't want to get it too deep. And you trigger it, and it pops a little incision there. And then on a piece of filter paper at timed intervals, typically every 30 seconds, you will touch the filter paper to the droplet of blood that's seeping out of the wound. 30 seconds, you touch it again, and when you can no longer get a droplet of blood, that means your blood is clotted, so that you can then look at the paper and see how far around it went, a timed interval every 30 seconds. Typically people will stop bleeding anywhere from, 2 to 9 minutes, something in that range, just depending. If the person is taking aspirin or they're on some kind of a blood thinner or anticoagulant, then that needs to be noted as well. Very simple test. Glucose tolerance testing is very much like a 2-hour postprandial sugar, except you're going to go over, it's more complicated, and it's going to be done over 3, 4, 5, 6 hours. This test is going to look at how your blood clears how your body clears glucose from the bloodstream over a long period of time. Rather than 2 hours like the 2-hour postprandial blood sugar, this is going to be perhaps, let's say, 5 hours. So 3 days prior to the test, the patient's going to be consuming 150 grams of that sweet carbohydrate drink called glucola. That's priming that insulin pump in the body, getting them ready. The day of the test, they're going to fast 10 to 12 hours, and they're going to show up at the lab. There is going to be a 0-hour blood and urine drawn, and then the person is going to drink 100 grams of glucola, and 30 minutes after that, a blood and a urine are drawn. 1 hour after that ingestion, blood and urine are drawn. 2 hours, 3 hours, 4 hours, and 5 hours, if it's a 5-hour glucose tolerance, blood and urine are drawn. So the physician then gets those results back, and they can see across a period of 5 hours how the body is clearing glucose from the bloodstream. So that can then be used to diagnose a number of conditions, diabetes and different conditions. It is long, it is drawn out, and it is very specific in how it's, all the particulars of how it's done. Read again in your book about it, because they go into great detail. Now, on that initial blood draw, before they give the 100 grams of glucola, if the blood sugar is between 140 and 160, up around that range, keeping in mind they've been fasting now for 10 to 12 hours, and it's 140 to 160 before you even start the test, well, that tells you there's already problems, because their blood sugar should be normal, 70 to 120, or even lower. Keep in mind they haven't had anything to eat or drink for 10 to 12 hours. So certainly their body should have cleared a lot of glucose from the bloodstream by that time. If not, then report it to the nurse. The nurse will typically contact the doctor, and then they'll advise what to do from there. That is the glucose tolerance testing. Wow, and that's it. How about that? All right, so lesson 6, the last lesson for this phlebotomy class. I'll get this posted up, and then please go over the quiz reviews that I did. So you'll have lesson 5, lesson 6, the ones that we've missed because of this corona lockdown, and quiz 5 and quiz 6 reviews. Go through those. Read your books 3 times. Please do not stop reading and studying. If you plan on taking the national test, it is challenging, as it should be. Study hard and then study some more. You won't have a problem. If you just kind of blow it off and think you go give it a try and see how you do, chances are you're wasting your time and your money, and you're not going to do well. Not that you're not smart, but you just didn't prepare. You've got to read the book. I've stressed it and stressed it and stressed it. And still I see class after class, typically half the people don't believe it, and they don't study properly, and they don't do well. Second time around they do well, but they've wasted their time and their money. So get prepared the first time, pass it, get out there and get a job. Thanks guys, it's been nice having you in class.